What is the key step in saving a patient's leg who has an osteosarcoma of the lower femur? Hi, I'm Dr. James C. Wittig, orthopedic oncologist and sarcoma surgeon, CEO and Chief Movement Officer of Mandala Medical Group. And I have over 25 years of experience taking care of patients with bone and soft tissue sarcomas and saving their lives and saving their limbs. I'd like to go over today exactly the steps that are used to save a patient's leg who has an osteosarcoma that's arisen from the lower end of the femur. And one of the key steps, or the key step in saving the leg, is being able to save the neurovascular structures. That's separating the superficial femoral and popliteal artery and vein and the sciatic nerve and its branches, the tibial and the peroneal nerves from the actual tumor. You can see here that this is a huge osteosarcoma coming from the lower end of the femur. This x-ray shows a permeative lesion with a very big soft tissue mass around the femur, and there's fluffy white cloud-like densities in the mass. That's an osteosarcoma. The patient would have been treated with chemotherapy first to kill the mass. This MRI shows you how large this mass is, and this mass is compressing and displacing the neurovascular structures. So in any limb-sparing surgery, particularly of the distal femur, it comes in different steps, and there are three basic steps to the procedure. One is planning the surgery and separating the important structures that you can actually preserve and separate from the tumor safely in order to preserve the extremity and preserve the function of the limb. With that included is separation of the neurovascular structures and saving important muscles that are important for coverage of the prosthesis at the end and important for protecting the prosthesis from infection and to get it to function. Two is actually resecting the tumor once you separate all these structures from it and reconstructing it with most often a metal prosthesis that's placed in, it's cemented into place, and it replaces usually the distal femur and the knee joint, because most osteosarcomas arise from the metaphyseal area, and in order to do the surgery, you have to actually resect the knee and replace it. And the third thing is then mobilizing the soft tissues, rotating muscle flaps to cover the entire prosthesis so that it functions and so that the knee works properly, right? And so that it's covered with good healing, well-vascularized soft tissue so that it protects the prosthesis from infection. Because you can imagine these children are going through chemotherapy. They're predisposed to getting infections when their neutrophil counts drop, when their white blood cell counts drop. And if they have, this is a massive surgery, if the wound doesn't heal exactly right, or there's a little communication where bacteria can get in, the prosthesis needs to be protected. It can't just be put right under the skin. In order to get the prosthesis to work, you have to move these muscles around to cover over the entire thing. And this is what the final x-ray looks like. Here's some intraoperative photos, and here's what the final x-ray looks like. Okay, I hope this is helpful, and you all have a great day.